We spoke about VPT, but we don't want to pass the message that this is the solution to every endodontic problem. Um, can this procedure have a boomerang effect? Ladies and gentlemen, welcome to Endocast, hosted by Ahmed Shauki. Hi, Ahmed.
Hi, Francesca, and of course by Francesca Ceruti. Today we have a really important topic, one that every clinician performing vital pulp treatment needs to understand. We are talking about the vital pulp treatment failure. What causes the failure, how it shows up clinically, and what are the challenges that can face the clinician during management of a vital pulp treatment failure. This is really relevant right now because the vital pulp treatment modalities have experienced a huge resurgence to the extent that the AEE, the American Association of Endodontists, as well as the European Society of Endodontology, have endorsed the vital pulp treatment modalities as a viable alternative to the conventional root canal treatment, even in irreversible pulpitis.
Absolutely, and the success rates are impressive, but still a subset of cases, so optimistically speaking, about 5 to 15% will fail. So let's start with the big question: what are the main causes of vital pulp treatment
Yes.
failure?
Yes, that's right. So the largest study that we have is coming from Asghari and his colleagues in 2024. They looked over more than 1,200 cases over 10 years, and they identified statistically significant, and let me say they are also clinically significant predictors of vital pulp treatment failure.
Okay, so let's go through them one by one. The first, and this is the strongest predictor, is the pre-existing apical periodontitis at the time of treatment. So teeth with radiographic signs of apical periodontitis had nearly 3 times the failure rate compared to teeth with a normal periapical status. So the message here is clear. So the worse the periapical status as baseline, the higher the risk of failure.
Yes, and the second major predictor is the pulpal diagnosis itself. This is very important, specifically symptomatic irreversible pulpitis. Teeth with symptomatic irreversible pulpitis have roughly twice the failure rate compared to those with reversible pulpitis. So, if we want to attempt vital pulp treatment, we need to counsel our patients precisely and appropriately about the slightly higher risk of failure in vital pulp treatment when doing it in teeth with symptomatic irreversible pulpitis.
Absolutely. And now the third factor is really interesting, and it's about the restoration. They found out the composite restoration were associated with significantly more failures than amalgam, and this probably relates to macro leakage. Now, let's say that I haven't never done an amalgam restoration in a patient since I started working, so probably this does not really apply to Europe because we don't use amalgam anymore. But why does this have something to do with bacterial leakage? Because bacterial leakage through the coronal restoration is one of the fundamental mechanisms of vital pulp treatment failure. Because if the seal is imperfect, bacteria re-enter the pulp space and the whole treatment breaks down. Duncan and colleagues, in a review published in the British Dental Journal, distinguished between early and late failures. So, early failures are those within 3 to 6 months from the initial treatment. So, they tend to be endodontic in nature, meaning the inflammatory status of the pulp was probably more advanced than we thought. And so we have the typical patient coming in pain to the practice. Late failures are more restorative in nature, so the pulp space gets reinfected because of a poorly sealed coronal restoration over time.
Exactly. And the fourth predictor of failure is the extent of caries, measured by the number of surfaces involved in the restorative procedure. Each additional surface increased the risk of failure. For example, teeth with 4 surface restoration had only 85% success rate compared to 93% for 2 surface restorations. So, the more the tooth structure is lost, this means less structural integrity, more exposure to bacterial leakage and contamination, and the less reliable seal. All these are connected together. Don't forget that.
Yeah, it's true. And there's one more thing worth mentioning, the time factor. There was a notable 14% decline in success rate between year 1 and year 5 in one multi-center trial, and in another study, success went from 89% at year 1 all the way down to 63% by year 10. This tells us that VPT failure can be a slow, progressive process and it's not always immediate. This is why long term follow up is so critical.
I totally agree with that. And now let's move to the second part of our discussion, which is the clinical manifestation. The question here is, how does vital pulp treatment failure actually clinically present?
We know that we have to look both to clinical and the radiographical criteria. And on the clinical side, we are looking for persistent pain after the vital pulp treatment, pain on percussion or palpation, swelling, either intra or extraoral, and the formation of sinus tract, for example. And of course, non restorable tooth fractures.
And on the radiographic side, we are watching the periodontal ligament space and the periapical bone. So, periapical index score of 2 and 3, and periapical radiolucency, which is periapical index 4 and 5, together with resorption and persisting radiolucency that is not resolving over time, is considered a sign of failure of vital pulp treatments.
Now, here's a really important nuance. Asghari and colleagues found that almost half of failures were asymptomatic. They were only discovered incidentally on follow up radiographs. And so the patient had no pain, no swelling, no complaints at all.
And this is a huge takeaway for all the clinician because if you perform vital pulp treatment and you don't follow up with regular radiographs, you could be missing almost half of your failures. And let me say that we always learn from our failures, so this is very important. And the European Society of Endodontology recommends a follow up on a clinical and radiographic basis at 6 months, 12 months, and then yearly up to 4 years. That protocol is essential. Now, the flip side of the coin, about the 17% of failures showed up symptoms within the first 6 months and nearly 30% within the first year. So there is a window where early failures declare themselves clinically. So take care of that.
And you have a case that you wanted to share on this topic, no, Ahmed?
Yes, actually, this case was very interesting because the patient was very young and he was presented with symptoms of severely symptomatic apical periodontitis as well as suppuration as well with a huge swelling. And initially, I have to inspect with clinically. So I found out that the restoration was broken in many points. This means, as we mentioned, that we have some bacterial contamination. And the reason for this, because young patients, especially in this case, young patients don't have just meticulous care about their teeth unless they have the guardian taking care of that. So the first one was the broken restoration, and then we had a radiograph that showed us that it was a vital pulp treatment, probably a partial pulpotomy or a direct pulp capping with huge radiolucency in the radiograph. So now we are implementing what we have just said about the restorative part as well as the follow-up part. And when we entered into the root canal system through the pulp chamber, we found that the material, which was probably MTA, I don't know which brand, of course, but it was soiled with biofilm infection. This means that the restorative part affected the outcome of the vital pulp treatment. And we have also improper technique because we have huge non-connected exposures that are sealed with MTA. In those cases, we prefer to get back to the proper diagnosis as well as selecting the proper technique for that case. So if I were in the shoes of the clinician, I would go for a complete pulpotomy rather than partial pulpotomy or direct pulp capping due to the difference in success rate as well as the size of the exposure. So when we face like this, we need to go back to the basics, which is a root canal treatment. We have to open the pulp chamber properly. We have to disinfect, and don't forget, especially in young patient, we have a lot of anatomy that need to be open to be accessible to our disinfection procedure. So now we are cleaning, shaping the root canal system, and finally we do the standard of care in the conventional root canal treatment. And don't forget that irrigation and disinfection in those cases are very important, very important. So you have to have a sound irrigation and final rinse protocol in order to overcome such soiled environment inside the root canal system. And at the end, we obturated, and you can see and appreciate that the root canal system is properly sealed, as well as we have almost complete healing after 6 months to 1 year. So this is a 1 year recall here on the screen, and you can appreciate that we have restoration of the architecture of the bone as well as the periodontal ligament space with no radiolucency. So my point here is the diagnosis. We have to spot the case in the correct stage that can accept vital pulp treatment. Otherwise, we are doing a wrong approach for treating and saving that tooth.
Yeah, and we have to remember that, above all, in private practice, we are the ones responsible in the eyes of the patient on what is happening. So we better choose wisely what the approach is going to be to the treatment. But all right, let's get into the third part, which I think is what many clinicians worry about most. So the difficulties of treating actually a tooth with a failed vital pulp treatment. And let's start with the elephant in the room, pulp canal calcification, or PCC. This is probably the most discussed concern because after VPT, the remaining vital pulp in the root canal can stimulate a progressive mineralization of the tooth. And so over time, this can narrow, if you're lucky, or potentially obliterate the canals. And this could make subsequent root canal treatment extremely challenging, extremely difficult, or so the theory goes.
Yes, in some studies, the authors make an important point. Even when calcification does not occur on a diffuse manner, I mean, it tends to narrow the canals rather than complete obliteration. And with the modern endodontic techniques like CBCT imaging, the dental operating microscope, ultrasonics, narrowed canal are generally manageable. But if the tooth has been pulpotomized, for example, for 10, 15 years before failing, the calcification picture could be quite different. And on the screen, you can see that we have huge calcification in the palatal canal, which is supposedly to be the widest canal. But due to the presence of vital tissues, which are not induced in a correct manner, so they are regressing by deposition of a lot of minerals, ended up into complete obliteration of the root canal system. And this will elevate the level of difficulty of the case from a very simple case treated with vital pulp treatment to a heavy and very difficult case that requires high magnification, ultrasound, clinical experience, and time. And this should be explained, by the way, to the patient, because when we face those failures, and let me say, not just failure, but they are also a side effect for the treatment, patient must be aware about what we need to resolve the situation.
Yeah, of course, because it's going to take you at least twice the time that it takes you to treat a regular tooth to approach such a case, and with higher risks.
Exactly, because when you have a calcified root canal system with some irregular dentinal structures and deposition of minerals, the risk of doing some errors as well increase. So we have to look at the far end of the story before we decide to commit the vital pulp treatments or undergo the regular root canal treatment therapy.
Yeah, and maybe if we find a case like this in the practice and we feel like we are not experienced enough or we have not the tools to treat it, I think these are the cases that is better to refer to someone else instead of trying to do the treatment and then get stuck in the middle with a perforation or a stripping or something similar. What do you think about this?
Yes, of course, because as long as the root canal system is intact, without any breach with our continuity with the periodontium, like perforations or something like this, so the success rate will be high. So, referring a patient that you cannot manage in your own practice is a good approach to save the tooth, because otherwise, if you don't know how to manage those cases, the prognosis will drop dramatically in a good tooth to be saved.
And you see that you finally made it to the root canal, and now you can.
Yes. Yes, by the way, I spent 2 visits to open the root canal system. 2 visits. Then we have to complete the regular treatment. So time is very important, and you as a clinician and the patient should know the boundaries of our treatment approach in order to reach a satisfactory outcome ending by saving a functional tooth.
Exactly. And there is another challenge here, that is the removal of the biomaterial itself. Because when you perform full pulpotomy, you place 2 to 3 millimeters of calcium silicate cement, like MTA, biodentin, bioceramic putty, you pick your favorite, but they are directly of the pulp stumps in the chamber, and these materials set into a very hard mass. And so removing them to access the root canals requires, as we were saying before, for calcification, careful technique, typically ultrasonics or dedicated burrs, high magnifications, patience, because you cannot be aggressive, because if you are aggressive you risk to create a perforation or to remove excessive dentine. And especially molars, where the furcation area is closed, you have to be particularly careful. One wrong move and you've created a iatrogenic perforation, which obviously complicated the prognosis significantly.
I totally agree with that. So we have to be careful when removing the materials. The third challenge relates to the altered anatomy of the tooth, the internal anatomy. Vital pulp treatments induce the formation of reparative or tertiary dentin and sometimes dentinal bridges. And this irregular mineralized tissue does not follow the normal pattern and normal architecture of the canal, so it can block or redirect the canal path, making the negotiation more complex and liable for more errors. you really need to understand the original anatomy and the possible regressive changes that happen after valve treatment with a good tactile sense to work through these obstacles, because these are really the challenge after you start doing work in your root canal system.
Fourth, many teeth that fail VPT were already extensively compromised by caries to begin with. And so, by the time you're doing root canal treatment, you might be dealing with a tooth that has very limited solid structure remaining, which raises another question of long term restorability. So, is there enough tooth left, or do I need a post, for example? Can you get a ferrule effect for a crown? These are decisions that should ideally be made before starting the treatment and not after.
Well, that's a great point. And the fifth challenge is more of a diagnostic one. As we mentioned, nearly half of the failures are silent. No symptoms, nothing appears on the patient. The patient himself or herself is confident about the tooth that it's okay. So the patients feel fine, and the clinician have to make a call about the judgment whether to treat, do an interference on an asymptomatic tooth that shows radiographic signs of failure, or you just monitor the case.
This is a very nice question. In the Asgari study, there is a place for watchful waiting in selected cases, but it requires very careful monitoring, and the patient has to understand extremely well what you're doing and why. That's what I think.
Yes, and there is one more management option worth mentioning, although sometimes I can oppose that: selective root canal treatment. And in the Asgari study, when it was possible to identify which specific canal or which root was associated with a periapical lesion after vital pulp treatment failure, they treated only that canal, preserving the vitality in the others.
Which is an
Strange.
approach, yeah. I would consider this approach very carefully, because at the end of the day, we are responsible for it, and we have to understand that we have to be able to manage the case if it fails. And so, if VPT fails, you have a toolkit of options: root canal treatment, selective root canal treatment, retry a VPT, which I would never do, sincerely, or in asymptomatic
Yes.
cases, continued monitoring. So, extraction is truly the last resort, of course.
Well said, and I totally agree. So, to wrap up, what are the key messages for our listeners, colleagues, and followers about Vital Pulp treatment?
Well, first of all, the main predictors of vital pulp treatment failure are pre existing apical periodontitis, symptomatic irreversible pulpitis, composite resin restoration, and extensive caries. Know these risk factors and counsel your patient accordingly.
Second, failure can be silent. Nearly half of the cases are asymptomatic. Follow the European Society of Odontology guidelines, clinical and radiographic follow up at 6 months, 12 months, and then yearly over 4 years. Don't skip the radiographs because we need to see our failures.
Yeah, most of the time the patient would tell you, yeah, doctor, I don't need to come, everything is fine. And you have to just tell it, no, you really have to take this x ray. And third, if VPT does fail, don't panic. Consider which options is best for you and for your patient, of course, and try to preserve the pulp when you can, but be prepared for when you can't.
Totally agree about that statement very, very much. And we hope you found this episode helpful, and we are waiting for your feedback on that specific episode for Vital Pulp treatment failures. Thank you very much for listening, and stay tuned for the next episode of Endocast.
Bye.
Ciao.
Ciao.
Ciao.